So this is an obstetric procedures talk about cesarean sections. So the indications for this, I guess first we'll start with the factoid. So in the U.S. at least, about 30% of births are done by cesarean section. So it's a very common way that people come into the world. And the most common primary indication, so that means the first time that somebody has cesarean section, is failure to progress. The most common overall indication, however, is a prior cesarean section. So let's think about failure to progress a little bit. So that has to do with the three P's. So the pelvis, the passenger, which is the baby, and the power of the uterine contractions. And that really boils down to two things. So you can have cephalopelvic disproportion. So that's a passenger pelvis problem, and then you could have power of contractions problem. So if you have power of contractions problem, you could try to augment that with oxytocin or rupture of membranes. And the definition, but if that fails, then you could find yourself in failure to progress. And so the definition of failure to progress is 2 hours without cervical change, with adequate contractions in the active phase of labor. So let's just quickly go over the stages of labor. So what's stage 1? That's from the onset of labor to full dilation, so to 10 centimeters. And you divide the first stage of labor into two phases. So one of them is the active phase, and the other one's the latent phase. So the latent phase is when you're having slow cervical change, and that's usually from about 0 to 4 centimeters. And the active phase when you're having faster cervical change. So if you saw the rate of change being plotted out, the rate would increase when you go into the active phase, and that usually happens after 4 centimeters. And so if you're in the active phase, you haven't had a lot of change after 2 hours, then you could find yourself, you could call that failure to progress. The second stage of labor, so that's from the 10 centimeters to once you're fully dilated to actually delivering the baby. And then you have the third stage of labor, which is delivering the placenta. All these have normal times associated with them. So if you're in the first stage of labor, to get fully dilated, if you're nulliparous, then the normal times for that would be about 10 to 12 hours. If you're multiparous, then that would be about 6 to 8 hours. The second stage of labor, delivering the baby, that again is divided up into nulliparous versus multiparous. Then you also add on an hour if the person has an epidural. So let's say the person's nulliparous and they don't have an epidural, then you say 2 hours. But if they have an epidural, you can get up to 3 hours. Then you'd still be in the normal in the second stage. If the person's multiparous, and then you say 1 hour is normal, you could add 1 more hour, so 2 hours if they've had an epidural. And then the third stage of labor, that's delivering the placenta, and the normal for that is about less than 30 minutes. So continuing on with their indications, so the way to think about it a little more detail is divided up into fetal, maternal, and placental causes. So fetal causes could be cord prolapse, non-reassuring fetal testing. So what would that be? That would be like a decrease in fetal heart rate variability or bradycardia. And you could have malpresentation. We're going to go over the presentation in a little bit. Maternal causes, so a prior C-section, that's the most common indication overall. And then you could have an infection like an HSV, an active HSV infection, or untreated HIV, cervical cancer. Placental causes, placenta previa, abruption, vasoprevia, with or without velamentous cord insertion. So what are the three types of placental anomalies, the three types of common placental problems? So the first one would be placenta accreta. So that's placenta accreta. And what is that? That's where you have the placental villi attaching to the myometrium instead of the decidua of the uterus. So they're sort of invading too far into the uterus. There's actually more severe forms of that. For example, placenta increta. That's when the placenta not only goes attaches to the myometrium, it actually gets buried inside the myometrium. And then the stepping it up from that, the even more severe form would be placenta precreta. So that not only goes into the myometrium, the placental villi go through the myometrium into the serosa or the surrounding organs, and attach there. So that's the placenta accreta, and more severe forms. And the way I think about that is creta kind of reminds me of concrete. So the placenta is like concrete; it's attached too much. Then you have previa. That's where the placenta attaches to the internal cervical os, so you're getting a preview of the placenta. Then you have abruption, that's where you have detachment of the placenta and bleeding. So vasoprevia and filamentous cord, we'll talk about that when we see a picture of filamentous cord in a bit. So just one note on VBAC, it's kind of good to know about this when you're talking about cesarean sections. because they're closely related. So this is vaginal birth after cesarean section. And so the general big idea is you can do this if you're in a big hospital with adequate facilities like surgery, anesthesia, and everything like that. And you can do this on a patient who's had a prior C-section with a transverse uterine incision. So if the person's had multiple C-sections, you might not want to do this. If the person's had a classical or vertical uterine incision or hysterotomy, then you wouldn't want to do this. The main concern with VBAC is uterine rupture. And if a person experiences uterine rupture, what they might feel is like a popping sensation. You might see signs of distress in the fetal heart rate monitoring. You might see hypotension if uterine vessels rupture, and you could also palpate fetal parts in the abdomen, like you might be able to feel a hand or a leg in the abdomen. And so here's we'll use this to contrast with the VELAMENTOUS cord. So here's a normal cord coming in. You can see it's sort of nice and tight all together till it attaches to the placenta. The vessels spread out and they sort of fade down as they get to the outside of the placenta, and the entire thing is a nice circle with no big divots or chunks missing. So when you deliver placenta, which is a common thing that you'll probably do, there's three things that you do. So the first thing is you make sure that you got the whole placenta out. So how do you do that? You make sure you look to see, are there any chunks or divots missing? And then you want to see that these blood vessels sort of tail off as they get to the edge. If you have a big vessel that goes right to the edge and looks like it was ripped during the delivery, what that could indicate to you is there's actually another maybe smaller lobe of placenta off to the side, and that blood vessel was feeding it, and that other lobe got ripped off and is still retained. So that's the first thing you want to do, make sure you got the whole placenta. The second thing that you want to do is to look at the vessels to make sure you have three vessels, so the two umbilical arteries and the umbilical vein. And then the third thing that you might do is get cord blood. So that's where you put blood from the cord. You just put a needle there and then put blood into a bunch of different colored test tubes. So here's to contrast that with the VELAMENTOUS cord. So in the VELAMENTOUS cord, when you get down to the placental end of the cord, there's an anomaly. The vessels aren't surrounded by Wharton's jelly, which is just sort of a gelatinous substance that surrounds the vessels and helps protect them. It's only surrounded by the fetal membranes. And so the way you kind of notice that is you see this. It doesn't attach nice and all together here. It sort of spreads out, and you can see the vessels spreading out like that. And then that can be a problem if it's associated with vasa previa. So just like placenta previa is getting a preview of the placenta, vasa previa is like you're getting a preview through the internal laws of the vessels, and so they're not protected by this Wharton's jelly. And if the vessels are there by the cervix, they could rupture, and that's why having a vasa previa, often associated with the VELAMENTOUS cord, is an indication for a cesarean delivery. And so, like we talked about earlier, we're going to go over presentation and position, because malpresentation is an indication for cesarean section. So presentation, that's just what would be coming out of the cervix. So this is the baby's head down like this, so that would be the vertex presentation. If the butt's coming down, that could be an indication for that would be an indication for cesarean section. That would be called breech presentation, as would transverse presentation. So that would be lying like this. And then position, so presentation sort of describes this orientation. So let's say we're in vertex, then we can talk about position. So we have the head facing down, but the head could be spun in any of 360 degrees. So that's what the position describes, is 360, the potential angles that the head could be. And by convention, it uses the fetal occiput and the maternal pelvis, the relationship between them, to describe this angle. And the way you figure out what the angle is you palpate the fontanelle. So you have this posterior sort of triangle-shaped fontanelle, and then you have the anterior, more diamond-shaped fontanelle. So you palpate those to figure out the angle that you're on. So we'll go through these pictures and just describe how you do that. So here are the fontanelles here. So let's say you've palpated them and you know that the occiput is up here. The anterior part of the baby's head is here. So we'll draw this line. So how do you describe this? You describe this as straight anterior occiput, because the occiput of the baby's head is in the anterior part of the pelvis. And so now we'll try this one here. So we'll start off with is the occiput anterior or posterior? It's anterior, so we're going to say anterior occiput. And then is it right or left? Right or left? So it's right, so we're going to say right anterior occiput. How about this one? Is the occiput anterior or posterior in the pelvis? It's posterior, so we say posterior occiput. And now we're going to go again with the right or left. It's right, so this is right posterior occiput. How about this one? Is it anterior or posterior? Well, it's neither. It's transverse. And is it right or left? It's left. So this would be left transverse occiput. So that's how you describe the position. All right, so now we've sort of moved on from all the indications type stuff, which is really important for cesarean section, and we're moved on to the procedure and anatomy review. So you start off with making a skin incision, and so you can do this thing called a finisteel incision or a transverse incision. And the sort of distinction is transverse means you're going straight, and finisteel means you're going at a little bit of a curve, sort of like a smile face. And this is a low abdominal incision above the pubic symphysis, and it's preferable to a vertical incision for a couple of reasons. Firstly, it gives you a better cosmetic look. It's also associated with faster recovery time and less pain, so that's why it's preferred. But a vertical incision could be quicker, so maybe if you're in an emergency type situation, you'll see a vertical incision done. And since you're going through the abdominal wall, it's good to know the layers. So you cut through the skin, then you go to the subcutaneous fatty of the fatty Camper's fascia, and the more tough scarpus fascia, and then you get to thinking about the rectus muscles and the arcuate line. Since we're here in the midline abdomen, so we'll just draw the rectus muscles here. We have the anterior rectus sheath here, linea alba in the middle, anterior rectus sheath coming over, and potentially a posterior rectus sheath beneath that. So with an incision like this, are we above or below the arcuate line? We're below the arcuate line. And so what would be here in the anterior rectus sheath? You have the aponeuroses of all of the three muscles of the lateral abdominal wall. So that's the external oblique, internal oblique, and transversal. So they're all traveling up here in the rectus sheath. In the middle, you have the linea alba, then you have the rectus muscles. After you get past the rectus muscles, you don't have the posterior rectus sheath anymore because you're below the arcuate line. Then you get to the peritoneum, and then once you're inside of the peritoneum, then you've completed gaining access to the abdominal cavity. And so you do all this besides the initial skin incision bluntly. You're just pushing everything out of the way like this. You don't want to cut through the rectus muscles. You just want to divide them and get them out of your way. Get into the peritoneum, and then you're ready to move on to the next step, which is dealing with the bladder. So there's two ways to do this, and you'll either do a bladder blade or a bladder blade with a bladder flap. And I'll just go to the next slide here to remind us of the general orientation and why you need to do this. So this shows the uterus, the rectum posterior, the bladder anterior, and remember that the uterus is covered by a layer of peritoneum that reflects up onto the bladder. I'm just going to draw the uterus like it would be in a pregnant person. It would be a lot bigger, and then so you'd have this peritoneum coming up around on the uterus, reflecting anteriorly onto the bladder. So you need to make this incision in the lower uterine segment. So you want to make sure that you don't damage the bladder when you're doing this. So the one way is you just use a tool called a bladder flap, which looks like this, and helps just push the bladder out of the way a little bit and protect it. And the other way that you could do it if you needed to get more access to the uterus, and the bladders really seem to be in the way, that would be to make a bladder flap. So to do that, you make an incision through this peritoneum here, and that's called the vesico-uterine fold. And once you do that, you access an avascular space behind it, which allows the bladder to help slide down off of the uterus. So that's a bladder flap, as you make this incision here in the vesico-uterine fold of peritoneum, and then slide the bladder out of the way. So those are two potential ways to deal with helping get the bladder out of the way so that you can do the next step, which is making the hysterotomy. Just remembering our surgical root words, otomy means you're making an incision in something, as opposed to hysterectomy, which would be removing the uterus. And so when you're doing this, it seems like it's scary because you're using a scalpel. You can't blunt dissect your initial incision into the uterus. You have to use a scalpel. So how do you avoid damaging or injuring the fetus? So you make this incision. The initial incision you make is small, and then you can grab either side of it with Alice clamps and help elevate the incision in the uterus, and that helps put gravity in your favor. So it helps gravity pull the baby down away from the incision. And you just slowly advance this incision until you get inside of the uterus, and then you can blunt dissect, which means pull hard and expand the the hysterotomy or uterine incision out this way to give you enough room to deliver the baby. Okay, so we've talked about that. So next step is delivery. Once that's done, then you do the placenta. So that's stage 3 of late. That's the third stage of labor, and so you do this spontaneously by just putting gentle traction on the cord. You're massaging the uterus to help prevent bleeding. You're giving oxytocin to help prevent bleeding. Once you deliver the placenta, you do the 3 things that you would always do, just like you're in a normal spontaneous vaginal delivery. So you check to make sure that there's the 3 vessels. You check to make sure you're not missing any pieces. You check to make sure that the blood vessels that you do see taper off as they get to the edge, and you don't see a big transected vessel towards the edge, suggesting that there's another lobe of placenta. And this time when you're massaging the uterus, you're really massaging the uterus. You're not massaging it through the abdomen. You're actually touching the uterus itself. And then so you do the procedures that you did to gain access to the uterus in reverse. So if you first close the hysterotomy, then you close the abdominal fascia, then you close the skin, and you're done. And so when you're closing the skin, that's frequently done with using staples, but it's also could be a good time to practice doing running subcuticular suturing. So you can click that link to check out how to do that, and I would ask to do that because it's a good chance to practice. And then you also might want to look at the surgical sterilization procedures, because those are frequently add-ons to cesarean sections. So complications. Hemorrhage, is good to note that the definition for hemorrhage in C-section is 1,000 milliliters versus in a vaginal delivery it's only 500. And so what are some of the causes of hemorrhage that we could brainstorm? What would be a cause of a big scary hemorrhage? That would be if you maybe like incised the uterine vessels or extended the hysterotomy into the uterine vessels. You could also have uterine atony, which that's a cause of hemorrhage in all deliveries. And then you could have placental things like placenta accreta. So bladder injury, that's why we use the bladder blade or potentially make a bladder flap. You can also have infection. So you could have endometritis, which is very common if people aren't given prophylactic antibiotics. So prophylactic antibiotics are very necessary with this procedure to prevent endometritis. You can have wound infection like with any surgery, and also thrombophlebitis is a good infection to know about. And that's an infection in the veins. Okay, so other complications, more general things, ileus, thrombus, and with or without an embolism. So the way we wrap these up, we'll do it the way it usually is done. So with the question review, so what are the common indications? So the most common indication for a primary C-section, failure to progress. Most common indication overall, prior C-section. Well, about what % of births in the U.S. are done via cesarean section? 30%. What's the definition of failure to progress? So that's 2 hours without cervical change with good contractions when you're in the active phase. So what stage of labor is the active phase in? That's in stage 1. So the latent phase and the active phase are both part of stage 1. What are 3 fetal indications for a cesarean section? Non-recurrent fetal testing, malpresentation, so breach, transverse, or cord prolapse. 3 placental indications: placenta previa, placental abruption, vasoprevia. What are 3 maternal indications? So prior C-section, HSV, or untreated HIV, some sort of infection, or cervical cancer. What's the difference between presentation and position? So like we talked about, presentation is what would come out. So if you're like this, baby's head, vertex, butt, breech, sideways, transverse. And then position describes the potential 360-degree rotation that the baby's head could be in. So that's and just remember the convention, it's the occiput relationship to the pelvis. So you describe that as is the occiput anterior or posterior, and then is it right or left? So okay, right anterior occiput or left anterior occiput. or any variation of that. So what's the benefit of doing a transverse hysterotomy? Why do you want to make that incision transverse? Just like you want to make the incision through the skin transverse, it's also good to make the incision on the actual uterus transverse. And a good reason to do that is it allows the potential for having a VBAC in the future. Let's think about the contraindications to VBAC. So as flows from the previous question, if you had a vertical or classical hysterotomy, then you don't want to do a VBAC. If you had multiple C-section, that's a relative contraindication. Then having inadequate facilities, that's another one. So the main concern when you're doing a VBAC is uterine rupture. So how do you notice a uterine rupture? The patient might feel a pop. You might see a drop in blood pressure if there's a lot of bleeding. You might palpate a fetal hand or foot or some other part in the abdomen which normally you couldn't make out so clearly. And then you might see distressed fetal heart rate monitoring. So the complications, so bladder injury, different types of infection, endometritis, like we said, is real common, wound infection, also thrombophlebitis, and then hemorrhage. This is one I threw in for like a trivia question. So what's a Bandel's ring? That's same as muscular constriction that circles the uterus and divides into upper and lower sections. So as you can imagine, I'll just draw here, this is a uterus and it has this constriction in it. So it's abnormally constricted here, sort of in the middle. And so what you can imagine that would lead to a cesarean section, for example, causing something like failure to progress. And if you did see this Bandel's ring, this muscular ring dividing the uterus up, then it could cause a problem with what you normally want to do, which would be this low transverse hysterotomy, because you might need to incise this ring to allow the baby to be delivered. So some things that you could ask about when you're doing this: how common is VBAC, vaginal birth after cesarean here? I think the rates really vary a lot depending where you are, and also they change a lot over the years. So you could get an update on that. You could also, I was curious about how when you're bluntly expanding the uterine incision, how do you prevent going too far laterally? So it seems like you're really pulling hard. How do you prevent sort of ripping into the too far laterally where you might hit the uterine vessels? And then you could also see what the person's take is on if the definition of failure to progress as being the 2 hours in the active phase without cervical change. Is that a good definition, or do you think it should be longer? I think there's controversy about this, and the person might think that maybe you should wait 3 or 4 hours before you start talking about failure to progress, as opposed to using a 2-hour definition. So that is the talk on cesarean section in the OB procedures.